So signs and symptoms of thrombosis, swelling, discomfort, slow infusion again. I would have trouble getting a blood return or flushing a central line in that state. I would not attempt, and that's why you guys will be taught when you start an IV or when you give an IV push med. In Adult Health 1, that is another high stakes. It's administering an IV push med. You'll assess the IV site before you do anything. But prior to ingesting or administering saline flush, you do what? You draw back, you aspirate back to confirm a blood flashback. Things like that before you administer. And you always have it in your practice that you administer any IV push slowly, typically over 2 to 5 minutes. Unless it's some special medication, like, for instance, adenosine. Adenosine, it's prescribed, it goes rapid push. But in general, all IV medications, it's very slow, 2 to 5 minutes. If you do have the situation of the thrombus, of course, you stop the infusion, you DC it, start another one, notify the doctor. Apply one compress. Pulmonary embolus, that's after the fact. It's already traveled. That's what happens. The thrombus has broke loose. Thrombus is broke loose and it travels. A pulmonary embolus, it breaks off and goes to the lung. Hence, embolus, travel. Embolus means travel. Air embolus. You could have this on ATI. It's possible that this might be on ATI. It could be a fatal situation. Happens most usually associated with the cannulation of central lines. The doctor's putting in a central line. And it's going to happen rapidly. I will tell you, I have never had a patient that this has occurred. I've never had this experience. I've had a patient with a fat embolus that they were in the ICU, young person. It was a bad situation. They arrested immediately. But I have never had a patient that had an air embolus. But these would be the manifestations that you would see, and the treatment. You clamp the cannula, put them on their left side, head down position. Position would be probably still there in the unit because it usually occurs with the insertion of a central line, usually. Air embolus, it's very fatal.
There's air in the tube though, right?
Well,
before you start the solution? So how,
if you, this is the other way it could occur. If you are the nurse that hooks up an IV and does not prime the bag, there you go, meaning that you've pushed all this air into the, you did not prime it with the solution. You could have, but typically those tubings don't hold up to 5 milliliters typically. It would have to be a pretty significant state. But in any case, do you know that any amount of air or those air bubbles, it causes concern, doesn't it? So, but this is a potential, a possibility that you could fail to prime your IV tubing, right? That could set one up for a potential air embolus. So y'all are gonna have this down pat. You're gonna know the common sense thing to do is prime my IV tube before I hook it up. Y'all know what I'm saying about priming the IV tubing, right? Y'all understand that, right? Have it totally primed through the tubing before you hook it to the IV. Caring for the site. You should make hourly rounds. You should document the IV site. Because the one person that's getting IV at 125 milliliters an hour, and you just check it, and as soon as you walk out the door, well, it takes a notion to infiltrate. See, things happen. But if you don't bother going back every hour, and you say maybe you skip and you come back in 4 hours, see, that's negligence, isn't it? That's negligence, because it's still infusing, but maybe a slower rate into the tissue. And we saw some pictures of infiltration. IV needs to be changed at most hospitals 72 hours. Now, I saw in your book where it does have up to 96 hours. That's like 4 days, and 72 is typical, barring no complications. You know, it could infiltrate, or patient could decide they don't like it and they take it out and say, here, you know, they'll do things like that. Replacing equipment. Bags are changed every 24 hours. That's the longest a bag will hang. IV tubing changed every 72 hours. Hence, what's also being changed is the IV site. Now, I know that there are some situations where we have such poor venous access, and there are times where you'll ask the doctor, I've assessed this site, and it's patent, it looks good, she's a terrible IV stick, and the doctor will write an order, say, may leave the IV in place for an additional 24 hours, but you've got to get a doctor's order for that. TPN, I told you about the parent, the person that had peritonitis, or anyway, the total parental nutrition solution has to be double checked by 2 RNs for accuracy. Pancreatitis, that's what I mean to say. That bag, along with its tubing, is good for 24 hours. Now, if that TPN bag is a small TPN bag and it finishes up, maybe they just hang it every 12 hours. It's every time a TPN bag's hung, you got to hang new tubing. TPN has very high dextrose solution. Dextrose is very harsh to the venous, to peripheral veins. Hence, most TPN is hung through central line, not peripheral. Most TPN, because dextrose is just so caustic to the veins. Only RN can hang TPN. And you check it, you double check it, just like you do in blood. You're checking TPN, make sure it's got the right components of what was ordered. Discontinuing an IV. And here's what I say to you guys. You get an order, say the doctor says, DC the IV solution. Now, common sense, if you just put that IV in, and he's written DC the IV, don't just up and pull out that IV. Just cap it off. Cap it off, because you don't know if you're going to get an order for a PRN push, IV push med. And what have you just done? You've just pulled out your good IV, so now you got to stick the patient again. I don't know about you, but I wouldn't like that. I'd be sort of upset. You can follow up once the doctor makes his rounds, say, now you do want me to keep this as a saline lock, don't you, Dr. Edwards? And he'll say, oh, yes. But on the other hand, guys, when they get discharged from the hospital, what do you need to make sure you do? Yes, please. Please don't send the patient home with a central line in his right jugular. Please don't do that.
My mom was almost sent home like that. She broke her arm, and we kept asking, please take it out, please take it out. We're done, we're leaving.
Yes.
And we had to wait there for an extra hour just to take it out. We signed all the papers and everything.
Yeah.
We were so irritated, we just like take it
But
out.
see, nurses have sent patients home and they failed to take out the IV lines.
They were just,
That's big no-no. Big no-no, guys. Don't do it. Don't don't wish yourself into that cornfield, because one of these people might have been a drug abuser. They just probably loved it. Instant access, right? Always, if you're getting discharged home, you know, doctor might not write that. Do you understand? The doctor might, he said, discharge home and here's the home meds. Follow-up appointment in 2 weeks. But you, the RN's, got common sense, don't you? When you see discharged home orders, if that patient has these EKG sticky pads on their body, you take those off, because they're not going to do it. They're going to say, well, I guess I'm supposed to keep these EKG pads on my body for life. And they do. They come back for those follow-up doctor visits still with them EKG pads on. I didn't know what to do with them, doctor. I left them on. Oh, by the way, what, you know, and this has all, of course, got infected and everything by that time, you know. What, I don't know what this is. Can you imagine? This common sense, guys, that's critical thinking. Common sense, critical thinking. You get discharge orders, unless that patient has had a PICC line inserted for a deliberate reason, that they're going to be followed by home health. You wouldn't, that you might not take out, or you would clarify with the doctor, now you want me to leave the PICC line for the home health nurse for the administration of the continuing antibiotics that they're going to receive over the next 3 weeks. Yes. You see that, right? But a peripheral IV, you're not going to leave that. A central line, you're not going to leave that. You wouldn't send a person home on a central line. You might not write these things, or she might not write them. But you, the RN's, got common sense, right? Can we all concur that? We won't forget what I'm saying, because if you do, you've got yourself in big trouble. Take those EKG pads off too, please. Don't leave them things on the patients. Okay, other venous accesses. I talked about the central line, and that's depicting right here, right? You wouldn't send that. You wouldn't let that patient go home on that. The PICC line, certified. You guys might become certified PICC line nurses. That's good business, because you can go make, you can work as your own boss, or you can work with an IV infusion company and go